Opening from sidekick to main villain, hello, top of morning. I am Dr. Ashutosh Mishra, consultant endocrinologist, Panacea Hospital. For years in lipid clinics and ward rounds, triglycerides were the sidekick, a number we glanced at after LDL, something to be fixed if time permits. Yet, as cardiometabolic evidence has matured, that quiet number has turned into a loud, disruptive villain, independently driving atherosclerotic cardiovascular disease, and at higher levels, tipping patients into acute, sometimes fatal pancreatitis. Today, in this brief journey, hypertriglyceridemia, from biochemical aberration to cardiometabolic syndrome, the goal is simple. Understand why triglycerides matter so much in diabetes and metabolic syndrome. Recognize the clinical spectrum from silent vascular risk to ICU-level pancreatitis, and explore how emerging agents, ApoC-ANGPTL3 inhibitors, and a new triagonist, DR10624, may change practice. Let us start at the beginning. A historical shift. The forgotten lipid wakes up. In classic lipidology, the story began and almost ended with cholesterol, especially LDL-C. Familial hypercholesterolemia, LDL receptors, statins, these were the main characters. Triglycerides were often dismissed as a messy postprandial nuisance. Then three things changed the script. First, familial chylomicronemia and familial hypertriglyceridemia showed us what happens when triglycerides go wild. Eruptive xanthomas, lipemia retinalis, hepatosplenomegaly, recurrent pancreatitis. Second, population data revealed that even mild to moderate hypertriglyceridemia was strongly associated with ASCVD events independent of LDL, especially in insulin-resistant and diabetic patients. Third, post-statin residual risk refused to go away, and a large part of that residual risk tracked with triglyceride lipoproteins and their remnants. In other words, what we once labeled biochemical noise turned out to be a very real, very dangerous signal. Classification and Indian South Asian context, clinically, triglyceride levels carve out the risk landscape we navigate every day. Mild 150-199 milligrams DL already linked with higher ASCVD risk, especially with low HDL and small dense LDL. Moderate 200-499 milligrams DL, classic atherogenic dyslipidemia territory in type 2 diabetes and metabolic syndrome. Severe 500-1000 milligrams DL, pancreatitis risk begins to climb. Urgent triglyceride lowering strategy is needed. Very severe, greater than 1000 milligrams DL, a red flashing light for hypertriglyceride-induced acute pancreatitis and possible multi-organ failure. In South Asia and certainly in India, the problem is magnified. Urbanization, high carbohydrate diets, fructose-heavy modern foods, physical inactivity, and central obesity sit on top of a genetic predisposition to high triglycerides, low HDL, and small dense LDL, what many now call the South Asian atherogenic triad. In OPD, this translates into young or middle-aged patients with diabetes, central obesity, TG 250-400, HDL in the 30s, and a family history of premature CAD-ORTH emergency admission with TGG greater than 1500 milligrams, DL, abdominal pain, and lipemic serum, where the question is no longer ASCVD prevention, but whether the patient will leave the ICU alive. So how do triglycerides climb in the first place? Mechanism: TRLs, insulin resistance, ApoC-T, and ANGPTL3 are the core. Hyperglyceridemia is a story of triglyceride lipoproteins, chylomicrons, and VLDL, and the balance between production, lipolysis, and clearance. Three processes are pivotal. 1. Overproduction. In states of insulin resistance and caloric excess, the liver responds by over-secreting VLDL, fueled by free fatty acids delivered from inflamed lipolytic adipose tissue. 2. Impaired lipolysis. Lipoprotein lipase is the gatekeeper for clearing chylomicrons and VLDL. When LPL is deficient, dysfunctional, or inhibited, triglycerideric remnants accumulate. 3. Delayed remnant clearance. When hepatic receptors cannot efficiently take up remnants because of apolipoprotein disruptions or receptor interference, atherogenic particles linger in the circulation and penetrate the arterial wall. Two negative regulators are now center stage. ApoC-E inhibits LPL, interferes with APO-mediated remnant uptake, promotes VLDL secretion, and is pro-inflammatory and pro-atherogenic. ANGPTL3 inhibit LPLL and endothelial lipase, raising triglyceride and lowering HDL. Insulin resistance upregulates ApoC and ANGPL3 expression and reduces LPL, creating a vicious cycle: high TG, more remnants, endothelial dysfunction, more insulin resistance. Genetically, when LPL or its cofactors are knocked out, we see childhood onset severe hypertriglyceridemia and recurrent pancreatitis, classic familial chylomicronemia syndrome. In contrast to more common polygenic or secondary forms ride on diabetes, obesity, hypothyroidism, nephrotic syndrome, alcohol, and drugs like corticosteroids or antipsychotics. But why should a clinician stare at a 300 or 900 on the lab report and feel uneasy? Because the consequences are far more than just a number. Clinical consequences is arteries and pancreas. First, the artery. Triglyceride-rich remnants are not innocent. They cross the endothelium, are taken up by macrophages without the need for oxidation, and form foam cells. They promote endothelial dysfunction, oxidative stress, and low-grade inflammation, particularly when coupled with ApoE and insulin resistance. Even after we optimize LDL-C with statins, a significant residual risk persists, especially in patients with diabetes, metabolic syndrome, and mixed dyslipidemia. Contemporary data point strongly to triglycerides and remnants as key drivers of that residual ASCVD risk. Second, the pancreas. When triglycerides rise beyond 1,500 milligrams DEL, the risk of acute pancreatitis rises sharply. Chylomicron overload in pancreatic capillaries, followed by LPA-mediated hydrolysis and local release of toxic free fatty acids, generates capillary plugging, ischemia, and a burst of inflammation. Studies show non-fasting TGs greater than or equal to 500 milligrams DL are associated with around a threefold risk of acute pancreatitis compared with less than 150 milligrams DL. Risk for pancreatitis increases roughly 4% for every 100 milligrams DL rise in triglyceride concentration above a certain baseline. Clinically, this means mild, moderate HTG, think artery risk and residual ASCVD risk. Severe, very severe HTG, think pancreas and ICU, with pancreatitis prevention as the immediate therapeutic target. Traditional tools, diet, weight loss, fibrates, omega-3s, niacin, good glycemic control remain crucial, but they often fail to normalize triglycerides in high-risk genetic or very severe cases. This is where novel therapeutics step in. Emerging therapeutics: ApoC ANGPTL3 inhibitors and DR10624. Two lines of innovation are reshaping hypertriglyceridemia management. 1. ApoC and ANGPTL3 inhibition. Decades of genetic and mechanistic work have established that loss-of-function variants in APOC3 and ANGPTL3 are associated with lower triglycerides and reduced ASCVD risk. Translating this biology into practice, we now have ApoC targeted antisense and siRNA therapies, e.g. olezarsen, plozasiran, that can cut triglycerides dramatically by 60% or more in patients with severe hypertriglyceridemia and familial chylomicronemia, while reducing pancreatitis episodes by nearly 80-90% in trials. ANGPTL3 targeting monoclonal antibodies and RNA-based agents that lower triglycerides, non-HDL-C and often LDL-C, potentially addressing both pancreatitis and ASCVD risk in mixed dyslipidemia and genetic disorders. These agents shift the paradigm from blunt TG lowering to precise molecular disarming of LPL inhibitors, especially in those who fail conventional fibrates, and omega-3 triple agonist DR10624 GLP-1 GCGF21 triagonist. The second revolution is more holistic. DR1624 is a once-weekly injectable triagonist targeting GLP, glucagon, and FGF21 receptors, designed to tackle triglycerides, liver fat, weight, and glycemia simultaneously. In a phase 2 trial of 79 adults with severe hypertriglyceridemia, DR10624 achieved triglyceride reductions of around 66-75% across dosing arms versus about 8 treated with placebo. Nearly 90 of treated patients achieved TG less than 500 milligrams DL, and almost 80% had greater than or equal to 50% reduction from baseline. Significant improvements in total cholesterol, non-HDL-C, HDL-C, and triglyceride-rich lipoprotein cholesterol, along with approximately 63% reduction in liver fat compared with about 8% with placebo. The safety profile so far is encouraging, mainly mild gastrointestinal symptoms and injection site reactions, typical of incretin-based therapies. Why is this exciting for us in India and South Asia? Because the same patient who walks into clinic with type 2 diabetes, severe hypertriglyceridemia, ASCVD, fatty liver, central obesity may soon be managed with a single weekly molecule that addresses weight, liver fat, triglycerides, and glycemic control alongside standard statins and SGLT2 inhibitors. Of course, big questions remain: long-term safety, cost, access, guideline positioning, but for clinicians the direction is clear. Move from ignoring triglycerides to formally integrating TG and remnant management to ASCVD prevention. Distinguish primary genetic forms from secondary lifestyle-driven HTG and personalized therapy accordingly. Consider newer agents, ApoC and GPTL3 inhibitors and triagonists like DR1624 for those who remain at high pancreatitis or ASCVD risk despite conventional therapy. To close, hypertriglyceridemia is no longer a biochemical footnote. It is a cardiometabolic syndrome in its own right, connecting insulin resistance, atherogenic dyslipidemia, fatty liver, pancreatitis, and premature ASCVD. For clinicians, embracing this expanded view and these emerging therapeutic tools is essential if we are to move from crisis management in the ICU to true prevention in the clinic.